with this, we move on to the next lecture by Dr. Nakul Sinha. He is head of the Department of Cardiology at present in Sahara Hospital, and he will be speaking on issues and challenges in ACS management. Dr. Nakul Sinha.
After this very interesting introduction to the platelet pharmacology, and in fact it's very important because unless we understand that, we won't move ahead in the direction of offering optimal treatment. So now we move on to why really do we want to focus so much on the ACS management. Now we are all aware that the cardiovascular disease mortality, it is very well known, I won't go into the figures, but it's contributing heavily to the global mortality scene. And out of the cardiovascular disease, coronary artery disease is perhaps the prime reason. Now, acute coronary syndrome, especially in our country, I mean, in the Western scenario, the figures may be going down, but in our country, there is still a 50% mortality sort of attributable to acute coronary syndrome. And even in STMI, 1/3 of patients are liable not to survive within the first 24 hours. And that goes for 15% of non-ST elevation MI. So basically therein comes the importance of risk stratification, that unless we have a good idea, or rather better than a good idea of how the patient is going to respond in the next 24 to 48 hours, we will not be able to focus on the optimal therapy regimes, including antiplatelet. So risk stratification will depend on the initial assessment and also on the continuous clinical assessment while the patient is hospitalized or as the investigations keep coming in on the bedside. So therefore the risk is based firstly on the probability that the patient is suffering from obstructive CAD, which can be rapidly proved by the modern diagnostic methods. And secondly, then what are the associated features which are causing as a comorbid conditions. We are all aware that there are many risk scores, but the most commonly used ones are TIMI score and the GRACE score. TIMI is perhaps much older, much simpler, but perhaps GRACE is the one which has shown a lot of new features and results. TIMI score, you are all aware, I mean 1 point for each of these 7 factors, and this is for non-ST elevation MI, not for STMI. There you use another score, and the mortality goes on increasing exponentially as you have more risk factors. Now GRACE registry obviously has been an ongoing effort for the last 12 or 13 years, and it has more than 1,20,000 patients now on its roll. And what it targets is that there are many basic issues which are sort of categorized while the patient is admitted, along with the findings at the initial hospital presentation, including the blood pressure, the physiological parameters, the creatinine, which is a very important byproduct of the mortality score, along with elevated or normal cardiac enzymes. And if we see here, I mean, once the score crosses around 140 or 150, there is a steep rise in the probability of having acute events. So the cutoff limit, if we just want to remember as a rule of thumb, will be somewhere around 140. And this is the model. It is available online, and in fact for the last 2-3 years I have just downloaded it on the iPad and kept that in the CCU. So for every patient who is coming, we just try and calculate the risk score and put it down as a documentation. Additionally, we should understand that it is the in-hospital risk which is given along with the risk at the discharge also for the next 6 months. So it's useful in both ways. Now, why are these scores important? Now, these very elegant slides tell us that if the hospital follows the guidelines, then we have better patient outcomes. So this red bars are where the guidelines were not being followed before the updates have been given regarding the scores. And these gray bars are when there is a reduction in the mortality, better outcomes of patients when the scores are calculated and guidelines are adhered to. And this is another sort of graph showing that if the even in the pattern of guidelines, if only less than 1/4 of the recommendations are being followed, you are liable to have a higher mortality. Compared to if nearly all the recommendations are being followed, there is a clear-cut reduction in the mortality. Now, we know the figures are climbing, not only for the incidence of CAD, but also for the complications. And at the moment, cardiovascular disease is the #1 killer. Now, if we see the burden of all the cardiovascular disease, unfortunately, coronary artery disease is the major contributor, overriding factor. So we just can't shun away from the fact that whatever programs have to be there for management or prevention have to focus mostly on coronary artery disease. Not to say that others are unimportant, but yes, these are the places where you have to focus most. Inter-heart study, as we all know, told us that the risk factors are similar. We are not too different, except that we have lesser prevalence of protective risk factors and more prevalence of diabetes and lipid abnormalities. And that leads to earlier age of acute myocardial infarction in Southeast Asia, which can be explained mainly by these risk factors. Now, we have also done sort of lipid study, which you may have noticed in the last issue of the Indian Heart Journal. I'm not spending time on it, but we had done a multicentric study in the state of Uttar Pradesh. And we have taken 8 big centers and pooled their data and then studied the lipid parameters. And we have come to the practically same conclusion that the younger onset of coronary artery disease is mainly attributable to the lipid abnormalities and the pro-inflammatory cytokines. Mortality burden, we all know if there is earlier disease, there is earlier death, more loss of manpower, rather disability adjusted life year figures are very adverse for our Indian population. CREATE study also told us practically the same thing. Besides telling us that there is a lot of problem in the patients reaching the correct place, getting the correct treatment, even getting the correct medicines like aspirin. If we compare the CREATE registry with the developed countries, what we see that there is a higher incidence of STMI compared to the Western countries, because there the ratio is reverse. You have lesser ST elevation MI and more non-ST elevation. Here you have more ST elevation. So perhaps we are going to change in the coming 5 or 10 or 15 years, but this is the reality at the moment. The depressing part is that we have more mortality arising out of the STMI and non-STMI compared to other regions in the world, which we need to set right. It is not that we don't have Indian data. As I told you, we had this lipid study. The Kerala group has done a wonderful work, presented their work in the ACC also, where they did this ACS registry and found practically the same findings. But here is the most depressing part. The depressing part is, according to this pure survey, which doesn't tell us good things about our own health system, that many patients who should be receiving the medicines in this group where the India was clubbed are not having so. This has the highest incidence of patients not receiving even one drug, 1 out of 4. The 4 being aspirin, beta blocker, ACE inhibitors, or ARBs, and statin. So this is really where our health administrators have to come in. Our health support system, our sort of social support system has to pitch in to better the compliance of medications. Now, I think most of the limitations of current antiplatelet therapy or antiplatelet drugs have been covered very nicely by Dr. Srinivas Rao, and I probably won't go into the details. Just very few, I'll just focus on two slides which are slightly different. I think all these have been covered. See, basically, when we started with clopidogrel, the thing was how much to give and when to give. So the current trial was extremely important because it tested the hypothesis that if you double the loading dose of clopidogrel and even in a 2x2 factorial design, doubled the dose of aspirin from 150 to 300 milligram, what difference was it going to make? Now, what we found that the double dose clopidogrel as a group didn't work. It worked only where the PCI was done and there was a dramatic reduction in stent thrombosis. But that was a subgroup. The total 25,000 patient group did not have much difference if you had 300 versus 600 clopidogrel. On the other hand, you had more bleeding. And additionally, there was no advantage of increasing the aspirin dose also. So you're better off with 75 milligram. That's okay. And I think this was also covered that if you try and measure the platelet reactivity and manage the dose of clopidogrel, it does not alter the outcome. So this Gravitas trial told us that if we are testing the platelet by the bedside or in a laboratory and then managing the dose, it's probably not going to work in the vast majority of patients. Of course, there are chances of increased bleeding, which can be a problem in very elderly patients. I think these slides have already been covered. I won't go into the details except that the newer antiplatelet drugs are probably trying to focus on the safety more, along with increased efficacy and the ease of administration, that you can give one drug to all the patients of acute coronary syndromes who are presenting there, rather than waiting for certain tests to come. And if you need to withdraw the drug for patient going for CABG or a patient at a higher risk of bleeding or who has shown a bleeding event, then you can withdraw it quickly. So these will be the two advantages versus the disadvantages of the present available antiplatelet therapy. We all know these warnings that patients may be genetically prone to sort of be resistant to clopidogrel, and as shown again, I mean, prasugrel works, but there is definitely an increased chance of bleeding. And you have to be careful about those three things which Dr. Rao very well is stressed about: the age, the body weight, and history of CVA. Trigger PCI, this was prasugrel is a stable CAD. Now this has been halted because the event rate is really very low. Nothing significant can come out. But we are awaiting the result of Triton, which is, TABI trial, which is prasugrel low dose, 5 milligram versus 10 milligram in patients of ACS who have been advised of medical treatment, non-PCI. So let's see, I think the results should be available by the month end. So in a stable CAD, there is hardly any role. In medically managed patients of other prasugrel, let's see, ticagrelor, we already know there is a role. There is hardly any controversy that now we should categorize the patient, see the risk score, and decide accordingly whether the patient requires some medical conservative management or an early invasive management. These trials have really pushed the corner. And even the ESC guidelines tell us that an early invasive strategy is recommended for patients with a GRACE score of more than 140 or more than one high risk criteria. The timing of strategy, we all know that it should be as early as possible. If the patient is low risk, well, the patient can also be transferred to a nearby PCI facility.
Nakul, you have 1 minute to go.
Right. I think we are done. Thank you.
Thank you.
Thank you, Dr. Nakul Sinha. It was an excellent presentation. And as Dr. Nakul Sinha pointed out that our problem in India is different with young patients, multivessel disease, more patients with acute coronary syndrome, probably we need a more effective antiplatelet